introductions about me, about the work we do at Aapti, and this event is being co-hosted in partnership with Swasth. So perhaps Abhishek or Urvi can also jump in and give a brief introduction to what Swasth does before we jump right into the topic at hand, which is consent managers and its application to India's healthcare ecosystem. I'm Saujanya. I lead some of the data and platform governance work at Aapti, more specifically data governance in the context of health. And Aapti's been involved on researching an approach to data governance called data stewardship, where we believe individuals and communities who essentially produce the data that is in this world should also have mechanisms to lay claims over it and benefit from it. And that's where our interest in the evolving landscape around consent managers comes from. And this event is being recorded, and it's a public event, and we hope that's all right with everybody in this room. And my communication so far also helped clarify that, I hope. And the event is being held in partnership with Swasth, as mentioned previously, but it's supported by Transform Health Coalition, which is a global network of organizations working in the advocacy healthcare space that is hosting the Digital Health Week, where they're looking at ways that would ways to transform healthcare in ways that are inclusive, equitable, and rights respecting in some ways. And it is in this context that we hope to explore the instantiation of the CM framework within India's digital health landscape, unraveling what it means for patients, for healthcare providers, for governments alike. And this conversation, I think, is significant for many reasons, because the CM framework itself is touted as one of the building blocks of the Ayushman Bharat digital mission, alongside other building blocks like the Unified Health Interface, the Ayushman Bharat health accounts, and so on. And while a version of the CMs is already being tested and tried out and rolled out in the financial sector in the form of account aggregators, we're yet to see it being applied across other sectors. And today we will be looking at the health sector specifically. Over to Swasth team, please introduce yourselves, and we can jump right in after that. Thank you.
Yeah, thanks, Sarojina. This is Abhishek. I'll take Swasth's introduction. So hi, everyone. Thanks for joining. And thanks, Aapti and Sarojina for having us as a co-partners in this event. So Swasth is basically a Section 8 not-for-profit company, mainly focusing on the digital public digital infrastructure in health. One of the key works that we are doing currently is another building block of ABDM, which is called Health Claims Data Exchange. Apart from that, our main goal is basically to create public infrastructures in health in such a way that everyone in the ecosystem can leverage and improve with the final goal of improving the health outcomes in the country. I won't take more in the interest of time. So back to you, Saujanya, for the proceedings.
Thanks, Abhishek. I just want to walk you through how today's conversation will happen. The first part of today's agenda is a short presentation, which I will give you about consent managers, what are the different definitions and interpretations, seeing as it features in the PDP bill as well as the health data management policy. We'll discuss a little bit about the significance of the CM framework and how it can be instantiated in healthcare, how Aapti is thinking through the significance, so to speak, and end with certain key questions for consideration. So I don't hope to take more than 10 minutes of the time to walk you through this deck, but it's always going to be around and we can draw from it, speak about it during the rest of the discussion. We will have an open roundtable conversation for approximately 50 to 60 minutes, followed by a Q&A with the audience or anybody in the call who would like to give their comments, and concluding remarks for the last 5 minutes. Hope this is all right with everybody. My colleague Vinay here is helping me with the deck, and Vinay, could you go to the first slide, please? Yeah. What are consent managers? So consent managers primarily finds its mention in clause 311 of the Personal Data Protection Bill, which defines consent managers as data fiduciaries who in some ways can help manage a data principal's preference over their data. So to be able to give, revoke, and manage consent is the role envisaged for consent managers within the PDP bill. The CM architecture functions in some ways as a clearinghouse for data through which users can make users can make requests of data holders to access an individual principal's data. And after obtaining express and informed consent of the individual, this data is shared from the data holder to the data user in an encrypted fashion. And more crucially, the CM platform does not store any data in itself. It's a data blind instrument, but facilitating consent-driven data sharing between two parties through an interoperable data exchange layer. The CM framework itself and the deck shows this is that it finds genesis in the Data Empowerment and Protection Architecture of 2020 and the Electronic Consent Framework, both of which are like the enabling policy mechanism that in some ways would catalyze the rollout of the consent manager framework itself. CM framework has 4 important attributes, and the deck mentions this. And to begin with, the CM is, I'm going to be using the term CM for the rest of this call. I hope that's all right. CM is significant because it adopts a tripartite model of data sharing where it places a express role for individuals as well as for itself in how data sharing is mediated. So on the one hand, you have parties who want access to data. On the other hand, you have parties who have this data, and CM in some ways is the communication protocol that connects these two entities, brings users into the fold to record their consent preferences, so on and so forth. And what is important under the PDP is that consent managers hold fiduciary responsibility. And because they hold fiduciary responsibility towards users, they have to act in the best interest. They have a duty of care and a duty of loyalty towards data principles. And the second feature of CM, which is worth discussing, is how it operates on an open architecture for data exchange. This in some ways follows the tradition of digital innovation that has come to characterize India's development experience. We have the UPI, which is in some ways a stellar example of how open protocols can work and scale easily. And CM is expected to follow in this footpath. And the CM architecture will comprise of several set of standardized APIs. And as I said, it doesn't store any data, but all data exchange is going to be end-to-end encrypted. Elsewhere, it facilitates dynamic granular consent controls. And this is important because as data principals, they can revoke consent at any time, they can provide consent at any time, and each of these consent transactions will be recorded, and there will be and each of these consent transactions will be recorded and maintained as a part of the CM architecture itself. And there is a consent artifact that is generated each time a transaction is made. Lastly, as I mentioned, the fiduciary approach to data exchange is one of its kind. Only the PDP bill speaks about it. And this means that the CM bears fiduciary duty towards data principles, which is you and me, and it includes a duty of care and loyalty, and it opens doors to accountability in so many ways, right? And accountability over how data is used, who are the people who have access to data, and so on. Right now, as I mentioned earlier, CM is being tested out in a version of the CM, rather, is being tested in India's banking sector, specifically in the form of a counter aggregator framework, which was discussed in 2016, notified last year, and there are important lessons to be learned from there. Vinay, next slide, please. Yeah, thank you. When we talk about the significance of the CM framework itself, right, and there is much to be said, and Aapti's thinking on this matter, we've tried to condense it and depict it in the form of an emerging framework that we'd like to call as the digital empowerment triad that is shown on your screen right now. As I said, it's an evolving framework and it's not entirely exhaustive in itself, and we hope to be able to refine it by way of today's conversation and feedback. But the framework has three nodes. One, which is that the CM represents a techno-legal approach to data governance, because you see that the CM is encoded in law and policy. In the context of PDP, it is law, and in the context of the health data management policy, which we will be discussing shortly, it's encoded there as well. And it serves as an instrument to realize data principals' rights over their data, whether it's the right to be informed, right to be right to data portability, so on and so forth. And it is linked to values of transparency, of data minimization, of accountability. All of these are guiding principles for any coherent data protection legislation. Lastly, as I said, and I've harped about this already, it's the fiduciary duties that is a crux of how CM is envisioned in the PDP bill. And it's important to keep this in mind, because you will see that the health data management policy doesn't have any any fiduciary duties that is ascribed to their framework of consent managers. And the techno-legal approach to data governance is only useful as the technical infrastructure which exists to be able to actualize it. And the technical infrastructure in itself works in tandem with law. And the technical infrastructure can be divided into two interlinked categories, which is open protocols and open networks. So open networks is an interoperable technical layer that will enable the rollout of CM. And if there are multiple third-party service providers who can function as consent managers, they will be able to plug in on this network and this interoperable layer. Open protocols, in some ways, is the standardized rules for communication that the CM will use to contact the data holders or users, and then the data requesters and so on. And this includes APIs, reference architectures, transaction mechanisms, ledgers, all of this, which would support the creation of a decentralized network. And decentralizing this network is also an important takeaway, because something like consent management cannot be centralized when it involves individual preferences over data to be tracked and recorded. And creating an open network that is available as an interoperable layer in which multiple parties can plug in is precisely how a decentralized network will function. Vinay, next slide, please. Okay, most of this slide is pretty much self-explanatory. There's just a diagram to show how the CM in the context of healthcare will work. But I will just draw your attention to the differences in the definition of consent managers under the PDP bill and in the health data management policy. So in the health data management policy, the most recent draft of which came out in 2022, defines CM simply as a digital system which facilitates exchange of health information and management of consent. It's subsumed within a larger category called health information exchange and consent manager. And this role in some ways is similar to the role envisioned for account aggregators by the RBI, and the CMs in the healthcare context, HIE CM to be specifically, does not have fiduciary duties. So going forward, I think we should keep this distinction in mind while we begin to discuss the rollout of the consent manager framework. With this, I think I pretty much covered most of what I wanted to say as a part of the presentation. And the last slide is just some guiding questions that we have in place to carry out today's discussion. But I will take a pause here and open this for a quick round of questions, if any you have from the audience. You can unmute yourself and or just drop the question in chat. All All right. All right. So
I had a I might be this is Setu from Microsoft. I think I might be out of sync, but isn't the PDP bill withdrawn? And how is that going to affect any of whatever is going to be discussed now?
okay, so I'm happy to take this for starters, but as you can see clearly on the slide that one of the bigger elephants in the room, I think the biggest elephant in the room is how in the absence of a comprehensive data protective legislation, can we innovate around health data in ways that are responsible and thing. The reason why I mentioned the PDP definitions of consent managers is because even though it's been scrapped, it is also the starting point of this conversation itself in some ways. And whenever it's going to come out or in whatever form, it is an important reference point nonetheless. So you will see over the course of the conversation, Setu, that people might speak about this a lot more, hopefully. I hope that answers your question. And I'm just, yeah. So, I'm just gonna jump right in to the discussion itself. One of the big questions that come up is, this is great on paper for people to be able to control how their data is used, but how are we actually going to roll it out, considering that India's digitalization experience, particularly in healthcare, is marked by breakdowns. More recently, we have the example of the COVID platform, and while it in some ways revolutionized how we think about vaccine delivery, it was also marred by problems in accessibility and affordability, with so many hiccups in the beginning, right? And bearing these experiences in mind, how can this HIECM overcome these bottlenecks? Are there any lessons to be learned from the past that we shouldn't repeat going forward? This is an open question, so anybody willing to answer, please unmute yourselves and go ahead. Anybody?
Hi.
Yes.
Yeah.
Please go ahead.
Hi, can you hear me?
Yes. Will you be able to introduce yourself before you start?
Yeah. Okay. So I'm Shifali Malhotra, and I'm with the Center for Health Equity Law and Policy. And yeah, I'm a health policy lawyer, political scientist, and health policy researcher there, and I focus on technology and health. To ask, to take on your first issue on digital divide, I think this is one of the biggest bottlenecks that will come in implementing this, this consent framework. And I think there will be two aspects to it. One will be, so while if you read the health data management policy, it makes it optional for the user to either go on paper or, use the electronic format. But I think it will be important in the policy to clarify that no one will be obligated to go to an electronic system. And if a user, the consent manager will have to, or the health information user will have to lay out both these options. Number one is that. Secondly comes the issue. So even if, when right now, if you see the situation, especially in rural and remote areas, telemedicine, telehealth is coming up in a big way. So even if we provide these options, I think there will be situations where paper-based consent will not be possible. And that's where digital literacy will come as a big problem. To think of a solution, I think one would be, one big way we would probably, what we can do is engage community health workers to become, sort of intermediaries between a patient and the system. But that will also, this is also, this also entails a lot of work. It will require, a lot of work with the community health workers, digitally training them as well. But I see that, as one of the avenues to make it more accessible to overcome the issue of digital literacy and digital divide.
Thank you, Shefali. That was useful. And not to tout our own horn, but Aapti's also been doing work on offline intermediation, and one of my colleagues can plug the links there. But I see Parag's hand is up, and I hope I got your name right, Parag. Please jump in.
Yeah, thank you, Sajanya. So I'm Parag. I look after partnerships at Meadow Doxper. So I think this is something that in our company also we've been grappling with. We try to build consent into our processes without any regulations in place and trying to look at best practices. But one of the biggest challenges we found is that the perception of what consent actually means in the public domain, whether it's the doctors that we speak to or the patients, there is very little understanding or appreciation that even consent is needed. Right? I mean, if you look at how this understanding will come about, firstly, people must value their own data, right? If they don't inherently value their own data, then what are they giving consent for, right? And also, can the consent artifact be simpler to begin with? Because, it's almost like we are skipping landlines, right? We went from skipping landlines, we're having nothing to straight into mobile phones. When there's zero awareness and appreciation of consent, this can backfire if people find it too complicated. Today, the consent artifact, if you look at what's there in ABDM, it's asking the user to give consent on many variables: the time, the type of content, right? When it will expire, the ability to withdraw. There is so many things that they're asking the user to think about. And right now, like, earlier, this was brought up just now, that consent is right now not even on paper. I mean, if you look at offline processes, nobody is even asking for consent on paper from the patients, right? So I think we have to take this in a very step-by-step manner. The consent artifact cannot be complicated. Otherwise, the burden will become on the provider to seek, the right type of consent, because the end user will not understand, what are they giving. The other point I'll make is, not all information has the same level of sensitivity. So you have regular personal information, and then you have very sensitive information, and then very, very sensitive information. So let's say your history around alcohol, drug abuse, or any other type of record. So I think we should also look at the type of content that we are asking consent for. So at the time of records, medical, especially since there's discussions around healthcare, when the record is being captured, right, can the provider label certain types of information as sensitive or ultra sensitive, so that consent artifact becomes more meaningful and the urgency is shown. So then the user knows, okay, we are giving consent for some information which is actually very sensitive. Otherwise, I think if I look at myself as a regular, consumer of healthcare, I would not want to be bothered by multiple requests for consent every time my data is flowing from one place to the other. I would rather, just give a blanket consent if I can trust the players in the ecosystem. So I think all of these things we have to take into account, and not just jump straight into having the most comprehensive, technically adequate consent artifact, because if technology could solve everything, then we would have, as a country in India, done a lot more already. Yeah.
I mean, that's completely valid, like the semantics of consent and also the urgency it's supposed to convey. And having differences in how consent itself can be given is important. I just want to bring in Ronak into this conversation. He's been is raising his hand for some time. Also, a small request that can we keep our interventions to 2 minutes and less, if that's possible?
Yeah, sure. Hi everyone, I'm Ronak from Bajaj Finserv Health. We have been working with NHS since a while and have built a PHR app as well. So I think the first thing that I wanted to focus on is like sensitizing users to essentially storing of records, right? While we are talking about consents and data sharing and all that. So I think what is more important at this point is ensuring that the user first understands what kind of health records are flowing in. While we have been able to create a lot of Aabhas and been able to fetch records, link records, and demonstrate that at least in POC levels, what is important is uh, ensuring that the records start flowing. Once the records start flowing is when as Parag pointed out, the importance of what kind of data is getting generated. The sensitization needs to be driven to the end user. In case of urban users, it may be PHR apps who are essentially driving the data. For example, if I look at a ThyroCare report today, it gives me like a lot of insights as to what parameter is useful, what parameter is not useful, like what do those parameters mean. So I think what first is sensitization of data by PHR apps in terms of smart reports or like in terms of various interventions which could be done. And in case of rural setups, it could be done by health workers. So I think once user understand what type of health data is getting generated and are able to figure out how where is it getting stored, how is it getting stored, and what can I do with it, is the is post that is when effective sharing of data will happen, right? And as Parag pointed out, most of the times the patient may not know what data needs to be shared to the doctor or not. Usually, in most of the scenarios, while granularity is good, but most of the scenarios, it will just be a blanket consent, which I provide to a provider once or which I provide to a PHR app once to be able to pull all my data or link all my data. So I think those are a few things which also need to be considered.
Agreed on wholeheartedly. And also perhaps this where I give my 2 cents, which is that blanket consents don't work. And while granularity is good, where you can see all the data points that might be given, but the significance of that data point needs to be sort of expanded into, and perhaps consider that CM should also satisfy some role of advisory as opposed to just mere data sharing. I want to quickly pass the mic on to Arjun and then Setu.
Thanks, Sojanya. Interesting discussion. I think on the subject of blanket consent, I likely agree with you. I don't think blanket consent works I mean, it may work in cases where you're sort of fairly convinced that you're somebody that the society in general may want to preserve and protect. But when you have any questions about whether you're a fringe element or whether you might be targeted based on your health data, that blanket consent just goes away very quickly as an option that you might want to give, right? So it's always conditional. Where am I? What's my context? And I feel like while the current sort of focus is on enabling quicker data sharing, and it's a noble pursuit, I think for the statistical majority, it would work for the most part. I feel like it's important also to, while we may take this current architecture as it stands and say, okay, let's just go ahead and use it because we need to move the data forward. It's also important to keep our eye on the need for nuance and further refinement. And I think that's the bit that I'd call out. That while my temperature of my records of temperature from 4 days ago don't tell the doctor anything about my temperature today, right? Same way, my records of consent from 4 days ago say, they may be assumed to say something about my consent today, but and it may be a good place to start, but it may not be necessarily the place we want to continue in, because in those 4 days, I may have discovered new information about my consent manager. I may not trust my fiduciary anymore. Information flows in different ways for different people. And I think in keeping that in mind, as we refine this is going to be important. I'll leave it at that. Thanks.
Wholeheartedly agree, Arjun, and perhaps you can talk a little bit about the framework you had in mind about CMs later in the call. But we have 3 hands up. So first Setu, followed by Sanat, followed by Aapti. Thank you.
Thanks. I kind of just a continuation of several of the thoughts that have been shared. I would like to actually, I was wondering, the way the focus is about data sharing here, and the assumption here is data is available and then it is being shared. But even the very aspect of collecting the data and linking with, let's say, for example, the ABA framework, if you are talking about, for every data, HIP has to take consent to even link that data. So let's say, for example, in a rural setting, there is an ASHA or a ANM who is providing services to a wellness record is created. There are 8 ANCs in a term, and each time there is a consent that is required. So probably there also has to be some clarity that comes up. It says that, okay, this person is enrolled in some kind of a program, especially if it's a government program, and so make it much more easier to even collect that data in the first place. So certain thoughts related to that, especially in the public health, because it's a big challenge. Every time getting consent even to link. Yes, there are some places where you could, if they go to a different facility, they definitely have to link or stuff like that could be there. But some thought in this might also be very useful, in my opinion. Thanks.
That's fair. Aapti?
Hi, am I audible?
Yes.
Great, thank you. Hi, everyone. This is Aapti here from the Center for Mental Health Law and Policy. I wanted to quickly come in to follow up on what I think Arjun was saying about consent and how consent changes on, what was given consent a week ago might change. And this kind of becomes really important in the light of mental illness and the idea of diminished capacity. So we work with Understanding the Mental Health Care Act 2017. And here the focus is very much on the individual, where an individual earlier, the idea was that a person with mental illness does not have the capacity to make their own decisions. But now there's a recent shift where, a person with does have capacity or is, supported decision-making to make their own decisions, so that autonomy is with the person. So in this case, informed consent does have a different meaning. And also it kind of, even with capacity, if you read the law, capacity is assessed if supposing you have a nominated representative making your, if you're not able to make your own decision, somebody else is making a decision for you, a nominated representative. The law says that, either 7 days or 30 days, this is periodically assessed. So same way consent also, there should be some way, if you're putting the rights of the person at forefront, to kind of keep revisiting that consent. And just putting the rights of that person in front, this is something, just an added layer of when informed consent has a different meaning. But I'll stop here.
I think that's a very important, intervention in so many ways, Aapti. And also, Mental Health Care Act is salient because it gives options to delegate consent in the form of advance directive and so on, which are, I think, useful touchstones that can be incorporated in versions of the CM, I'm guessing. I think Sanat Kumar has his hand up, followed by Shivali. So, yeah.
Yes, how's Sajanya? Thank you for this meeting. And my question, regarding Arman. Arman is a organization, it's a social organization. We're dealing with, we work very closely with government data, health related. For pregnant women, they have a database. We procure that data through health workers, and it resides in government database. So a lot of activities we do in making calls to those pregnant women for supporting them during pregnancy, during high risk, is done through IVR and WhatsApp and other mechanism. So taking the data out of government database, out of their premises and running it on a cloud has become a challenge. Getting that acceptance, even though we're just taking the phone numbers and dialing someone, but the data is very sensitive, and the government, we have to work with the government to be open to that. So any lights on that, getting government's acceptance towards this consent framework, and so that we can utilize government data, for helping out these pregnant ladies without breaking any policies.
Sanat, while that's an important intervention, I request that we come back to this towards the end of the conversation, because we want to keep questions for later on. What you can do, however, is record your questions in chat, in public chat, so that we can revisit it. I'm so sorry, it's in the interest of time only. I want to draw attention to a couple of people we haven't heard from, but who have been listed as speakers for this conversation. Aditya, Akshay, please jump in. Vivek.
Hi, Sajanya. Aditya this side.
Yeah.
Hello, everyone. So I have been leading the product side of Ayushman Bharat Health account with ABDM. And this is a very interesting conversation for us and gives us a lot of feedback on the work that we have been doing. One point from the product side was to enable or sort of bridge the digital illiteracy in the country is to have a program-centric approach where we are reaching the last mile through beneficiary-led programs. And collection of consent can be in an assisted mode where it's just an idea at this point where we are trying to enable sort of a model which has an interface on the facility operator side and an interface on the user side, where the user can have a graphical interface and be assisted by the facility operator to have a consent. Of course, I understand that the consent cannot be very granular in this case, but this would go a long way in enabling consent mechanisms for these sort of users.
That's you're opening doors to discussing the second question, which is precisely this. You are envisioning a role for consent managers as data intermediaries who sit between data requesters and data providers on the one hand. But I think that leaves questions about what are the rights of patients in this context, how is health data governed in this, and consent managers only facilitates consent provision to the extent that it's shared in that particular instant. How are you going to cover for things like data reuse, right? What if the person who gets the data decides to use it beyond after they receive it for purposes that are not mentioned in the initial consent artifact? So Akshay has his hand up, and then I will go to Shurojit, who is also a speaker at this roundtable. Yeah.
Hi, I'm Akshay S. Dinesh. I'm a doctor programmer with extensive experience working in rural, tribal, and government facilities. I have 3 points. One, the average Indian citizen can operate a mobile phone and watch YouTube and pay at a shop with Google Pay with no problem. There is no problem in literacy. But the bigger problem compared to digital literacy when it comes to India's healthcare system and consent manager is that our health system is highly paternalistic. There's a huge power differential between the healthcare system and the consumers, that is the patients. And there is simply no meaningful consent possible in a power hierarchy like the one we have. And even the offline processes, I mean, especially the offline processes, are highly likely to become a checkbox that you tick at the entrance or when you're getting admitted to a hospital with absolutely no informed consent in that process. So if anyone remember getting your vaccine and being automatically assigned an Ayushman Bharat Health Authority ID, then you know how consent works in health system. About 12 crore accounts were created with this quote unquote consent. So point one is consent is meaningless in India, and consequently the only way to protect people is to actually have strong data protection laws, without which none of the rhetoric on consent managers can be trusted. The second point is that the language on consent manager is probably hiding something on how much of a problem consent managers are creating. If all data is encrypted, why is there such strong words that consent managers cannot store data? I mean, if all that is passing through is encrypted data, what can you do with the storing that data? What is this consent artifact? Someone else mentioned it right now. How much data is contained in consent artifact? And it's supposed to be kept as a ledger. The ledger of consent artifacts is a gold mine of metadata. That itself is enough incentive for lots of people, whoever has already built consent managers, to get into the business of consent management. And they have no incentive to be responsible to protect the rights of citizens. So just like what UPI did to payments and account aggregator is doing to bank accounts, the consent manager becomes a third party who I didn't invite, who my healthcare provider did not invite, and who comes in between my relationship with my healthcare provider and with no accountability to me, suddenly starts negotiating on behalf of me, my health data with all kinds of third parties. And there is a possibility of scope creep happening in that. And my last point, third point is that I have to make this point because of how frustrated I feel as a community health practitioner. When are we going to actually look at the needs of healthcare in our country? What we need is a responsive health system that put people at the center of it. Data exchanges, consent managers, and things like these, and nobody have asked for this. Hospitals, primary health centers with staff, essential medicines, right to healthcare, free treatment. These are things that people are asking for. When are we going to even look at this? I rest my points.
Appreciate your intervention, and I wholeheartedly echo some of the scope creep concerns that you've expressed. But Shefali, before we go to you, I wanted some voices from within the provider community to also intervene here. So Shurojit, do you want to jump in? Ronak, Parag, all of you, some of the questions that Akshay raised hit at the heart of healthcare provisioning, right? And do you have anything to add in this context?
Sure. I thought this was a round table, so I came prepared to say nothing because I don't know I don't know anything about this. But it's good to have 67 people speaking at once in the interest of democracy. I'll start by saying that sorry, I'm Shurojit Nandi. I represent Raxa Health. We do tech. And I personally am a physician and a scientist, and I work on tech. I think that the only thing I'll say is that if you look at the Bohr report is in 1946 set up the blueprint for the Indian healthcare system, in which we would have a primary health center every 30,000 people, and it was a great blueprint. Unfortunately, the Bohr report in 2022 has not been realized yet. And I think we in India, as planners, have a great tendency to overstep our, to like build a sort of a big castle on a hill without, without being able to actually implement it. Consent is a very, very important thing. But like many of the people have said, I mean, I'm a clinician. I've worked in countries which are very, very litigious, the United States, and people there do not understand consent. So informed consent is not really something that can be implementable. The reason it works in healthcare in the United States is because the provider is supposed to have a fiduciary relationship and therefore a responsibility to the individual patient. Now, when we apply, if you transfer that to India, as many of the speakers have said already, I think that the idea of informed consent becomes even a further, like a khwabi pulao, something that is unimplementable, as well as the idea that once you do, beware of the things that, if you do do consent. So we are very, very interested in consent at Raxa, and we've, for like 7 years, we've been building, I think, a very, very good consent system. The problem is that if you build it, you are not sure that what you've built is what is going to be the consequence of it. So I'll give you an example. If you go to Google and you download a app from their Play Store, and you click on there, agree, like all that stuff. Everyone knows about this example, right? And Google is trying to make it as granular as possible, but there's a whole set of things that people, including Google themselves, can do with the data that if you knew what they actually were and all the consequences were, you would never agree to, right? So the problem is that having done that, the people at Google, and I'm not trying to take a shot at Google. I think Apple does this. Everyone else does this. We do it. But the reason why informed consent works so well in a fiduciary relationship is because a provider has a one-to-one and therefore a fiduciary relationship with the patient. A doctor does, of course, other providers as well. Until consent can reproduce that idea, I think this will be a very, very hard thing to implement in the way that people, just like the Bohr report, it'd be very, very hard to implement in the way that people envision it. So that's my 2 cents, and I'll stop talking now. Thanks.
Thanks, Shurajit. And if we are talking about reports that need to be realized, we have the Alma Ata Declaration from the 1970s and the 80s, and it set a vision for equitable health data, health for all, but sadly, we don't see it being coming alive anytime soon. But let's see if CMs do. However, I see Parag and Vivek have their hands up. Please feel free to jump in, Parag, followed by Vivek. Yeah.
So I think Akshay made very hard-hitting and very important points. And I think one useful way to get around this is to, I think, stop comparing ourselves with the fintech sector or, what RBI is doing. Because I think we made this mistake earlier also when we looked at the success of Aadhaar and we said, okay, health IDs are also going to go down that same path. And while that's unidimensional, that's an ID, when you talk about healthcare data, that's not, one-dimensional, right? Like your financial data. And also the fact that, in the financial sector, you have very large players. It's not as fragmented. Even when you look at the UPI apps, it's a finite number, right? But if you look at Indian providers and the different type of stakeholders, not only is it very, very fragmented, it's just very, very different, depending on which city, location, language you're in, what socioeconomic background you come from. So I think one useful starting point would be to look at health as health and not compare it with, because there is this pressure, right? That, okay, we were successful with Aadhaar, with UPI, and, let's just try to bolt on that same speed and that success, and hopefully it works the same way in healthcare. I think this forum itself shows that there's a lot of things that still need to be worked out. And I'm sure this is not the first time these are things that are being talked about, but we can take this in a phased-wise approach, stop comparing ourselves with other sectors, and then that will bring the sense of humility that we have a long way to go, and we don't necessarily have to solve for everything on day one. Yeah.
Great. Vivek?
Thank you, Sarjanya. I think just rounding up a lot of things that folks have said, right? And it's been a great discussion so far on the concept of HICM and the concept of informed consent, right? I think just to sum everything up, right? HICM cannot exist in a vacuum, right? Even the PDP bill that we have earlier talks about data controllers, talks about data fiduciaries, talks about data processors, so on and so forth, right? And we need to have the entire ecosystem set up for any of this to be effective to any extent, right? And without those pieces in place, it's pretty much meaningless in terms of whatever happens. And again, as Surajit said, informed consent will always be a pipe dream. So when it comes to adoption, that's the real question that, at least to give everybody context, I was working in NHA till about a few months ago. And when we start talking about adoption, the lack of these other players who perform these extremely important roles is a big impediment to anything being done in this entire ecosystem. And therefore, it is important that we also, in the same breath that we're talking about rights and health information exchange and consent manager, in the same breath, we also start talking about, how we're going to set up data fiduciaries, how we're going to set up data processors and data controllers within this health ecosystem, because without that, none of this would be possible.
Agreed. And it's a question of creating enabling infrastructure of scale, of capacity. And I think in so many ways, that's the next question. Ronak and then Abhishek.
Yeah, so just to build on to Vivek's point, right? Like when NHA started off with the whole concept of a PHR app, so then like all of us realized that even though I pull data, I need to be able to store data, which is where Locker comes in. So what we also need to realize is the consent managers as entities are essentially to help the end user applications, which could be like the practice management solutions or the PHR apps, to be able to allow data sharing. They cannot, as Vivek pointed out, they cannot exist in silos, right? So the concern which came out around like somebody just coming and wanting to be a consent manager, so it doesn't, like, while in concept it works, while in the technology stack or the architecture it exists as a different entity, but they are essentially there to help applications on both sides do their job more effectively, right? Because somebody may want to build out just a practice management solution, but may not have the right infrastructure or capabilities to be able to store data or manage data, right? So I feel that like, while there is a lot of concern around concern managers, what we also need to understand is they are helping someone else do their job better, rather than looking at it in silos.
Oh, sorry. Abhishek, please jump in.
Okay, thanks. Very, very intriguing discussion, and I think a lot of the points that people are bringing to table, we need to kind of take into account. But I think I would like to extend a little bit, because just trying to play devil's advocate here on Ronak's point, that I think we are trying to look at the consent manager as an infrastructure, as something of a feature, saying we don't need this because it's not digital, things are not digital enough and all. And what you also need to look at is what Ronak said. More and more health data is going to be digitized. And this is not something that even if government doesn't do, even if no consent manager exists, that's going to happen. And when data starts getting digitized, there is real concerns anyone can raise about how those digital copies of data can change hands. Okay. And while we know how what is exists today is not enough and maybe the first step, but I think we should also think about, don't we need such infrastructures to make sure that inadvertent, like the impending digitization of health data doesn't go into a laissez-faire affair where anyone who has the digital copy of data can do anything with it without the patient being involved. So while the framework may not be effective in what it is today, but don't we think such infrastructure is needed? And if it is needed, maybe the discussion should also focus on that what should be the next steps, or the uh, or the necessary things to go with the current infrastructure that will make it effective uh, in many cases to prevent the harm, and then also get it also enable something. I think we are just looking at it from the perspective of how it was trying to enable something, but I think it's also and again, it's trying to look at the thing from a 360 perspective rather than just focusing on one aspect of it, that people are not digitally literate right now. And in fact, that's even more the danger. They are not digitally literate, and their hospitals are, and other health providers are, and other health intervening agencies will digitize their data. And if there is nothing available, then there's no stopping them from sharing anything to anyone. I'm sorry, but I think we should also pay attention to that aspect.
Agreed, precisely, which is what brings us to the third question on this slide, which is about what is the infrastructure we need to be able to actualize this. Like Ayushman Bharat digital mission has been rolled out. It's available for health facilities as well as us as individual patients or whoever to enroll voluntarily, and in the, like, what is the actual infrastructure one needs to be able to actualize this if this sort of innovation is here to stay. And we have two hands up, Arjun as well as Shivali, and I also want to bring in more voices from the Aditya, hopefully, who can talk to us a little bit about what are the next steps on it, the CM framework.
Yeah, bridging a bit between the intermediaries question and the enabling infrastructure question. I think the answer really is in where are the incentives, right? Who has the incentive to set up a consent manager? who has the incentive to pay for the servers, the data transfer, all of that stuff, the security, and what is that incentive rooted in, right? Is it simply a matter of trading data, or is it more than that? Is it also a legal duty imposed onto the consent manager? Is it also a regulatory compliance imposed onto the consent manager? How are the incentives or disincentives managed? I think is the sort of underlying uh, bedrock on which your enabling infrastructure would lie, right? So I think just making that upfront.
I think incentives is always the question. What is the incentive to join the ABDM, but also in some ways, what is the incentives to create? And Shefali, after you're done, we'll go back to the practitioner side a bit as well. Shefali, any intervention here?
Yeah, hi, thank you so much. I just, to bring in points for your third question, and also to add to what everybody has said about informed consent. I think there are two things that are really important here, apart from the consent framework and how will it be implemented. One is how will we manage incidences, or how will we ensure integrity of the data that will pass through the consent manager? What will be the data security protocols, and how will access requirements be implemented? I think that is very crucial, especially considering that there's been a recent report that India has the second highest number of health data breaches happening in the world, and so that becomes very crucial. The second point is on accountability of consent managers. So I think the way the health data management policy is drafted at this point, I think there is no accountability that is there for for the consent managers. So to give you two small points, one is that if you see the grievance redress system that has been set up, for ignoring the deficiencies in that at this point, but that grievance redress system is only applicable to data fiduciaries. It is not applicable to consent managers. So if some leak, or if somebody is unhappy with how their data has been processed by the consent manager, what relief can they go and seek? And secondly, and the other point is that without a data protection law, you just cannot have adequate enforcement. You cannot have adequate penalties. It is, we need a data protection law for that. And it becomes very, very evident from the way the enforcement provisions of the health data management policies has been drafted. Thank you.
I echo your concerns about the data protection thing, but I want to shift the needle a bit on this conversation in terms of like on the practitioner side, but also on the practical considerations for implementation, right? So are there any best practices that we can employ in this context as consent managers are being contemplated? Perhaps there are enough consent managers and people producing these applications who are part of the sandbox right now. Aditya, Abhishek, I saw that your hand was up. So Aditya, any intervention on this? Abhishek, any intervention? And I want to again draw this conversation to the health facilities and providers side of it. How do you think a good consent management system, one that can incorporate these concerns, be built? Yeah.
Yeah, a point here from the infrastructure point of view. So NHA has been promoting low-cost HMIS solutions that are ABDM enabled. This would help small practitioners, clinics, single doctor, like 10, 20 bedded hospitals to come on board ABDM, or more importantly, to digitize health records and create a data-rich health ecosystem in the country. A best practice here could be borrowed from the UPI model, where the push happens from the consumer side by scanning a QR code. So we have been piloting certain use cases where the facility has a QR code which is intent built, and the user sort of scans the QR code through their PHR applications and pushes either their identity or their health record. By identity, I mean this. What we have envisioned is that this sort of fastens registration process at hospital counters. So we have been running pilots, and of course, as previous speakers have mentioned, the consent manager, building the consent manager framework rests on a lot of pieces, and it's not a standalone piece here. And the building would require push from both the patient side as well as the provider side here. And provider side needs to see the incentive in the network effect that consent manager or digital health records at large would bring.
Interesting. The network effects argument has been ever so strengthened by UPI, and always endearing to hear that. Ronak, Parag, perhaps Shurojit again as well, because
Yeah. So I think we have been trying to like our solution at Bajaj Finserv Health has been integrated with ABDM since a while, and we have onboarded some 30 doctors and facilities. So whenever at least the few doctors that have visited, right? So there's this option to create ABHA. The facility manager or the doctor can create ABHA for the patient. So whenever we try and speak to these doctors to see why you're not linking records, right? One of the concerns which come is like even for creation of ABHA or linking records to an ABHA, there's a consent which is needed. Like an OTP, the consent is given in the form of an OTP. So there's a lot of hindrance on the side of patients to essentially share OTP because the patient is not sure why would my OTP be needed, right? So I think what as Aditya pointed out, I think the QR code model where the patient is themselves giving a consent in the form of to link their record via the QR is one way to solve it. And I think QR has been a big success in UPI, which is where I feel people are now used to, and even when restaurants, people are used to scanning restaurant like QRs to essentially view menus as well. So I think OPD registration and linking of Aadhaar to the prescription, if it can be solved the QR way, I think that is something which will drive adoption and which will essentially educate the patient that you are giving your consent for your records to be linked, right? So that is one way of solving it, because I think initially in the time of Aadhaar as well, a lot of us could just put a fingerprint and get geo SIMs, right? Where essentially we were giving a consent for our data, for our Aadhaar data to be shared with the provider so that a SIM can be issued. So in case we can come up with similar models using QR, using the provider scanning the Aadhaar card of the patient. So if these sort of initiatives are tried, I think that will essentially start building the trust in the patient that yes, my data is being taken so that, or my consent is being taken so that my record can be linked and I can fetch it onto any PHR app or a locker.
Before Parag goes on, what both Aditya and Parag and Ronak mentioned about the QR code model is interesting, and we do see widespread adoption. Like most days, most people step out of their house without a penny in their pockets, but can be rest assured that they will not go without being able to buy anything, mostly because we have our phones and the QR codes. But I also just want to ask this to the wider audience: is there any best practices that we can apply from the account aggregator rollout? Because like right now there are 1.1 million accounts which have been linked to AAs, 1 billion accounts, and that includes 12 banks, large PSUs. So any lessons from there? Perhaps it's too early, 1 year in, but worth exploring nonetheless. Parag, all yours.
Yeah. So I'm going to, Sajana, again, apologize. I'm going to play devil's advocate here. We keep comparing ourselves to finance sector and UPI. Here's why I think the tool is not the incentive, right? I mean, QR code is great, but UPI is peer-to-peer, right? And health data, what will I do sharing it with another person, right? It's like, I think somebody mentioned, it's a very asymmetric power relationship right now. It's between the provider and the patient. It's not patient to patient at all. So let me address the consumer part, and I'll talk about best practices. We are experienced working with a lot of doctors, right? So on DocSpur, we help doctors digitize their case notes using a digital pen and paper. So we've been doing this with thousands of doctors in individual clinics and hospitals. So we've tried, even before ABDM, right? We tried to build in consent practices on the provider side. So I'll talk about that in a moment. But on the consumer side, I think the bigger incentive is going to be when data starts to get monetized. Okay. So if you look at the real world data now that's happening globally, and US FDA has also approved this in the last several years, where for clinical trials or for research purposes, you can use real world data, and you can actually incentivize people to share their data, in exchange for their data to be used in clinical trials. So until we bring at the consumer level some incentive for them to share their data, let's say with pharma companies or clinical trial companies, that might kickstart this whole awareness and incentive on the consumer side before even we talk about the providers coming in and are requesting this information, right? So this is my views on the consumer side. I think while we can build tools to get them to share their data easily or share their consent easily through QR codes, we have to look at really the macroeconomic side of this, right? And what is the data worth to different people? On the provider side, we tried a few things. We said, okay, can we and understand consent, right? Before we can even share it, the first part of consent is I'm giving consent to you. If you look at the IT Act, I'm giving as a patient consent to my doctor to store my data. So you're using an EMR, you're storing my data either on the computer or on the cloud or even on a piece of paper in your cabinet. If you look at the IT Act, there has to be at least consent for even storage. So even when we try to print, let's say, the consent statement on the prescription pad, the doctor was telling us, I have no awareness about this IT Act. If I ask my patient for consent every time he comes in, right, the patient will also get irritated. They will not understand why the consent being asked for. But as a best practice, as a company, we thought, as a responsible tech company, we should bring this concept out and educate the providers that, look, even for storing the data, let alone sharing it with another provider, just the fact that you need to store your patient's data as per the IT Act, you need to even get consent for that. But even that level of awareness was not there, and there's a lot of resistance. So we have to really, look at all of these issues and not just, what's happening on the sharing front. Yeah.
While I tend to agree about it from the perspective of consumers, I have my reservations about making money the incentive question, right? And the example you mentioned, the use case from the FDA context and how data monetization is being considered. I think that's a separate conversation to be had. Abhishek and perhaps Shurojit next. Yeah.
Yeah, I think Shuro was before me. So Shuro, why don't you go first?
Sorry.
Shuro?
Okay. What exactly should I respond to? I think that I think we have. Sorry. Go ahead, Sujani.
I was just saying it's a question around enabling infrastructure to support this transition. And how do you create a space for CMs and build CMs with the right sort of technical infrastructure?
Okay, so sorry. So I think I was alluding to that in my earlier comment that I think we have sort of we must be wary of getting into solutionism, where just because we can build something that seems like a solution, it actually is one. I think almost all of the commenters here have pointed out that that informed consent and privacy. Another person on this call once said to me that if you're in government for long enough, you realize that privacy is a myth, and this is really true. So the question really is not that if we can ensure adequate privacy or ensure adequate consent. I think no one can. But if there's enough of a cost that is exacted on someone who is trying to be a bad actor, so that when they do so, so there's a disincentive for it. That's to me the question. I mean, for example, there are great examples of how anonymization doesn't work, right? So if you take a picture of someone in New York, you can actually find their location just by other cues in the photograph. You don't need a GPS location for that. And the more data you have access to, you can easily track them, which tells you that privacy, if you can take a picture of someone and that's allowed, you can do that if you're within your own rights, is a myth. In the same way, consent and privacy in the medical space is also fairly mythical. But it costs us money to pay a private investigator to go and track the like a recalcitrant spouse or whatever it is, and that there's a disincentive to that, and then you may get caught and all kinds of things. You can restraining orders and things like that. I would love to see a focus in the consent manager people, not on trying to create a great thing. That's obviously necessary. We can come up with solutions up and down, but I'd love to see someone mentioned laws, but something that is actually enforceable, where a cost is exacted on those who break those, expectations.
Abhishek, you can go, but before that, someone plugged an important link in the chat, and I encourage everybody to look at it, Ronak. He's talking about how dispute resolution and having that embedded in platforms can help build consumer trust. This picks up about Surajit's point as well, right? While there is an over-reliance on the concept of tech solutionism, but we also need to build tech that is responsive to consumer needs. And I leave it at that. Abhishek, please.
Yeah, I think, and again, now trying to kind of take from everyone, and I want to kind of take forward from Parag's and Shuro's point. See, I think tech alone cannot be the solution, and I think when we talk about enabling infrastructure, it cannot be just the tech infrastructure. Tech infrastructure is a necessary but not a sufficient condition. It is required. So I think we need technology infrastructure and it to go much further than where it is today, agreed. But then we need the policy infrastructure, we need the incentive infrastructure. Incentive infrastructure also means the disincentive infrastructure. We need resources and resources in the sense, let me give you an example. According to my understanding, consent in health is not new. All health service deliveries have consent built in of some type. Right? When you go to a doctor says, may I examine you? Most good doctors will say, unless whatever. So, but is that well implemented? Is that not well implemented just because of the technology missing there? Or is that not well implemented because the incentives are missing there or the policies are not there? So I think the way we need to look at question number 3 is that, is there only one type of infrastructure we need to look at, which is technology infrastructure, or do we need to look at technology infrastructure in conjunction with many other infrastructures which are required to interplay to solve the problem? And I think I agree with Shuro's point that by reaching to QR code as the solution, we were trying to jump too many steps forward. I mean, in Assam, the solution may be very different from how it will be in Kerala. We don't know, right? And health is multicolored. We all agree to that. So I think we need to expand our conversation that what are different enabling infrastructures needed and how can they be made to come together. Grievance redressal system alone is not enough. A grievance redressal policy, which that system, and that's the reason you named it in your slide as techno-legal. I mean, there is no legal aspect to it. The techno alone is not sufficient, right? So I think somewhere, we are we getting carried away in one dimension, either in technology dimension or in saying that consent manager is not needed direction. But maybe all of this needs to come together. Technology acting as an enabler, but we also need enforcers in terms of policy infrastructure. We also need another enablers from cultural and educational aspects. Someone, I think it was Parag who initially raised, unless a person values their own data, they'll give consent to anything, which most of us do by telling Google, yes, we agree, just because we wanted to play a game. We don't even know what it is collecting from us. So I think all of those also needs to be thought as a point of both point number 3 and 4, not just the what are the good technical solutions to kind of make something happen. Unless all of those come together, I don't think it's going to work. But back to you.
I completely resonate with what you're saying and just want to take a moment to give my 2 cents about what Abhishek and Shorajit and everybody else has spoken about. Yes, the reason why the Digital Empowerment Triad speaks about not just technical infrastructure in terms of open networks and open protocol, but also speaks about techno-legal infrastructure, right? We're always caught up in this dual race where technology is growing by leaps and bounds while law has to keep up with it. So we think something like the CM, which represents a, in some ways, a combination of the two, inscribing the CM in law, saying that the CM will perform as these functions and ascribing fiduciary duties. Fiduciary duties exist between me and my investment banker as it exists with me and my doctor. Perhaps my consent manager should also carry fiduciary duties. And to be able to do this, the consent manager needs to expand beyond its role of merely facilitating data exchange, perhaps talk about data advisory roles, right? And explaining, really laboring to explain to people what is the data that is being exchanged, why, for what purposes, and what are the avenues available to people to troubleshoot any misgivings. And this is where the legal and supporting policy infrastructure comes in. And as Shifali Malhotra mentioned earlier, but this slide on question 5 also says it, we don't have a personal data protection bill. And in the absence of a personal data protection bill, we are left relying on 1, the courts, and 2, our IT Act and the sensitive data rules of 2011 as the only regulatory support that can be extended to protect our data. And as we know in this country, institutional approaches like institutional bottlenecks like approaching courts exist. So any innovation needs to be kept in should bear in mind that you need additional policy support, and whether that policy support comes from the state or whether the platforms themselves adopt a responsible approach to how they use the users' data, right? And having platform level conditions and internal policies about how data is used is also important, is something I agree. And there are examples of how platforms are trying to do this. And some of this is effectuated by law and for compliance reasons, but otherwise also certain platforms are moving towards a more responsible paradigm for their relationship with users. Yeah, so that's my 2 cents. Is there anybody with their last comments? We have 3 minutes before we close this part of the discussion and open to Q&As and concluding remarks. So anybody last comments? Last comments, anybody?
Yeah, my name is Shankar Prasad. Can I talk for a second? Yeah.
Yes.
Okay, I've got a question now. We have now the PHR address, and using PHR address, we are storing data in briefcase. Is that right, wrong? Is there a future approach how we should do this?
Anybody who wants to take that question?
Yeah, so essentially what happens is, this is Ronak here from Bajaj Health. So essentially what happens is, whenever you set up a PHR address, so there are companies which are providing the locker services, right? So think of it like a Google Drive for that example. Like if I can use my Gmail ID to store data in Google Drive, so I can use my Gmail ID to store information in my Gmail account or OneDrive, right? So similarly, you use your Aadhaar ID as an identifier to fetch records from any of the providers where you have linked a record, and you store that onto briefcase. Today you are doing it in briefcase, tomorrow you may want to do it in Aabha app or Paytm or any other app for that matter. So the data is, so you are the patient is in control of their own data, and they decide what locker to store their data in and fetch their records from providers.
If we give the data to a doctor, is there any is that consent? And who owns the legally? Who owns the consent? Or if the doctor breaks the rule, are there any rules provided by NDHM as to how to handle this situation?
So the data is accessible only for the time that the doctor has requested the data for. And the data is, because you have stored it with briefcase is responsible for sharing that data to the doctor. And the platform that the doctor is using is essentially responsible for storing the data for that much period of time. After that, it has to kind of delete the data essentially.
And legally, who is finally responsible if the data is misused?
So,
I'm
so sorry to cut you short. We're running short of time, and if there's a important question, please write to us. We can take it up. I see that Arjun has his hand up. Please, Arjun, your comments.
Yeah, I'll try to close with a partial response to Dr. Prasad's question. So I think the question you're asking is who is legally accountable if the data is misused. And to the best of my understanding, at the moment, the way the draft health data policy listed out, the penalty is lack of or debarment from participation in the national digital health ecosystem, right? And that's the extent of which the policy provides for. So that's the answer to your sort of core question. But I think the broader question that you're asking this forum is it right or wrong to use a health data locker of some kind, right? And I think the answer to the question really lies in how much do you trust the forum, and it's really a question of trust. This is what, say, Ronak told you, or what I told you, or what Virginia told you in this discussion. You would make an informed choice, right? And that is really the crux of the consent discussion. Who do you ask for advice? And I think Virginia sort of alluded to this a bit. Data advisory becomes a big sort of area to look at. Whose advice do you trust? When we tell you that, hey, this is what the implication of using a health data locker is. Do you trust us, or do you feel that you need to do further research, or is your level of threshold of hesitation to use a system like that met or not? And I think that's really going to determine the adoption or lack thereof of these systems. So I'll just leave it at that.
Thank you, Arjun. We have one, interesting question in chat from Gyanikan, where the person's asking, are the implications more complex or similar for telemedicine? Anybody wants to take this up? Anybody from the practitioner side? Abhishek, seeing as Swasth was formed as a telemedicine app.
I think I did get the question. I mean, if the question is sharing data without permission, do they have different implications? I think that depends on data sensitivity. It doesn't matter which.
I think it's a little bit about how CMs will play out in the context of telemedicine.
I think the use cases would be something like if you go to a second doctor or a third doctor and you want the prescription or the data produced by the first doctor to be available to the second doctor. I mean, you can use the CM to give that permission to the third doctor or second doctor. Those kind of use cases could be there. There can be many such use cases, but I don't think that was the question. Was that the question?
Yamikan, are you in this call? You can clarify, but if anybody has any final comments or question, now is the time.
Last question. I never heard the word blockchain in this whole conversation. Should that be used or not?
I'm not a tech person. I'm a policy person. So the tech enthusiast and the tech specialist in the room, please weigh in. Personally, I'm wary of everybody who says blockchain is the solution. So
okay, we are using it, so I just wanted to know.
And no, sir, I don't think blockchain features anywhere close to these questions of, at least in the Indian landscape, not yet. But Arjun seems to have his hand up.
Yeah, I wouldn't wager so far as to go into blockchain, but the notion of a distributed ledger and shared data sets might be actually interesting to a fiduciary consent conversation, though I haven't seen a good implementation.
Thank you, guys.
Interesting. Distributed ledgers and Web3 have come to occupy a fair bit of mind space for all of us in this room, I hope, I'd imagine. Any last comments? Shefali, Aditya, Ronak, Parag, Shurojit, Abhishek, all of you. All right. I think we're almost at time, and I want to take this moment to thank everybody who could make it to this call. I don't know if consent managers make for an exciting Friday evening discussion, especially at the end of a very long week. But I do hope it makes us think a little bit more critically about how our relationship with our own healthcare providers, with our own data, and so on. And it also, in some ways, throws open more questions than it has answered. How can we responsibly innovate around data? Should consent managers have advisory functions inscribed in them? Can technological innovation follow a set blueprint in the form of QR codes? Or is there something more at play given the sensitivity attributed to health data? While we contemplate this, we will also hope to condense all of these inputs in the form of a policy brief that we hope to be circulating in the next week to 10 days as an output from this conversation. I'm personally available at, I'm going to just park my email in the chat, and all of you on this call must already have my email. But if anybody is interested in our work, please reach out to me and we'd be happy to speak to you. Abhishek, any final thoughts from your end?
No, thanks for the opportunity. I think we need to look at consent in the context of what we are trying to do, and also in the context not just of saying how we are looking at 5 use cases today, but in general things saying that data is going to become more and more digital, and how do we provide good infrastructure to responsibly protect as well as share that data, because overprotection is also not right, and sharing without any limitations is not right. So how do we create that balance? And I think we should look at consent manager framework and the infrastructure as that infrastructure which allows for this balance to exist in the ecosystem. And then look at it from that perspective, that what is the immediate needs. I don't think it's trying to define the needs, but it's trying to help certain needs wherever they exist. So that would be, and it's a complex conversation. So I think 1.5 hours is never enough for such kind of conversation. So thanks everyone for joining in and providing your thoughts. There have been a lot of good points coming out of the discussion today. So thanks for that.
Thank you so much. As I said, will circulate the policy brief in the next week to a fortnight. And in the interim, if you have any questions or comments, please do email. Thank you. Bye-bye. Have a nice evening.
Thanks, everyone. Yeah, bye-bye.